Good morning, everyone. Welcome. We'll just wait a moment. It is currently 10:01. We will start in about 1 minute. It's fantastic to see the number of participants jumping up. We're well over 100 now. Okay, let's get started. Good morning, everyone. It's February 10th. We are delighted that you have taken some time to join us this morning. Welcome to a webinar with OARC and our Ministry of Long-Term Care. Thank you for taking the time to participate. We're grateful to our ministry partners from the Long-Term Care Pandemic Response Branch for recognizing the importance of directly communicating with residents, with the goal of providing communication with residents that is unambiguous, clear, to ensure ultimately that residents are well informed about pandemic-related changes that affect their lived experience. This is the first time a webinar such as this has occurred, and we welcome the notion that it will be the first of many. We all have the same goal in mind, and that is to share pertinent government announcements and directives, and to provide a platform for residents to pose questions and engage in meaningful dialogue with government in real time. Thank you to everyone behind the scenes in both government and OARC who made this happen today. My name is Dee Lender. I'm the Executive Director of OARC, the Ontario Association of Residents' Councils. Melissa McVie is also with us from the OARC team. She's the Director of Education and Communications. Before we get started, you will notice that we've muted participant audio in an effort to eliminate the background noise and possible distractions. A reminder is that this session is being recorded, and that is for educational purposes. It will be available for post-webinar viewing, accessible on OARC's website. We have protected a time for questions and answers at the end of today's webinar, at which time we will invite you to type your questions into the question box. It's likely that we won't have time to get to everyone's questions, but please be assured that we will capture all of the questions after the webinar. We will circle back with our ministry partners with the intention of creating a question and answer resource to share more broadly following our time together this morning. So without further delay, I'd like to give a warm welcome to our panel of guests today from the Ministry of Long-Term Care. We have Erin Hanna, who is the Associate Deputy Minister, Long-Term Care Pandemic Response. We have Dawn Mallett, Director of Long-Term Care Projects and Stabilization, and a number of people, government representatives from their team. We have another Erin, we have Maria, we have Sarah, Danielle, and Nancy. So welcome to our guests. And without further ado, I would like to turn the time together over to Erin Hanna. Good morning, Erin.
Good morning. Thank you so much. Good morning to everyone who has joined us today. I want to echo Dee's comment about how exciting this is, this first time ever webinar with residents and for residents. I joined the ministry as the Associate Deputy Minister for Pandemic Response in January of 2021. So well into the current COVID-19 pandemic. And it has been an incredible learning journey for me, and an honor and a privilege to be able to work with individuals who are striving to make long-term care better in Ontario, including the Ontario Association of Residents Councils, and the opportunity to hear the voices of residents and your perspectives directly through different forums, whether that was through task teams that we had created under the Response and Recovery Advisory Committee, or through the more recently established Strategic Long-Term Care Advisory Table, which is really an opportunity to hear voices as we go forward with the government's overall transformation plan for long-term care. Our focus today is on the changes that we have made to the guidance and our plan forward to ease the temporary enhanced measures that were put in place in response to the latest wave of the pandemic, often called the Omicron wave, and in particular due to the high transmissibility of this variant of COVID-19. And also our colleagues from the Office of the Chief Medical Officer of Health, Dr. Sarah Erdman and Danielle Reimer, who are going to talk about the changes that the Ministry of Health has made with respect to protocols associated with outbreak management. We hope that the material today is informative. We hope that it helps to understand and raise awareness of the changes that we are planning for and how those can impact, hopefully, to improve your experience and quality of life within homes across Ontario. And I just, again, want to echo Dee's comment about let's hope that this is the first of many. My commitment is to continue to engage with resident voices, both through information sessions and opportunities to respond to questions that you may have, and also through other forums. So one of the projects that we'll be working with Dee and her team on going forward is creating a community of practice that can engage residents and their perspectives as we continue down this transformation path over the next couple of years. It's an honor and a privilege to be here today, and just thank you. Thank you for the invitation, and thank you for being on this journey with us as we look to change and improve how the ministry works. So thank you. I'm going to turn it directly to our first presenter, another Erin Mannix from our team within the Ministry of Long-Term Care's Pandemic Response area.
Thank you, Erin. Good morning, everybody. As everybody said, we're so happy to be with you this morning and talk to you about these measures. So with that being said, I want to jump right into it. And as you can see on the screen right now, we have a bit of a timeline of the evolution of the temporary enhanced measures that were put in place. And these were put in place to provide optimal safety for residents and the staff who provide care within the homes. And these were informed by advice from the Office of the Chief Medical Officer of Health. So before diving into it, I want to note for you in the bottom right corner, there's a couple acronyms. So GV is referring to general visitors, and SSV is referring to staff, students, and volunteers. So in looking at this timeline, before the Omicron variant, there was no limit to caregiver and general visitors. There were no restrictions on social absences, and fully vaccinated individuals were exempt from surveillance testing. So for those who aren't aware, that refers to the testing conducted prior to an individual's entering the home, whether that be staff, students, volunteers, anybody that's coming into your home. In mid-December, the immunization policy came into effect, requiring general visitors to be fully vaccinated in order to visit indoors in the home. And there were a maximum of 2 people for indoor visits and 4 people for outdoor visits. Over this time, we increased our surveillance testing efforts to identify any positive cases and stop them from entering into the home. By the end of December, the province saw a large increase in Omicron cases, resulting in access being paused for general visitors entering the home and social day absences for residents being paused. So it's important to note that during this time, caregivers and general visitors were able to visit residents receiving end-of-life care regardless of their vaccination status, and that all essential medical and compassionate day absences were permitted. Next slide, please. So in looking at easing the temporary measures, we took a look at the evolution and looked at how we could scale that back based on the way that it was implemented. So we're going to walk through in each category here. So for general visitors right now, as it's February 10th, the general visitors are still paused, as you can see on your screen, but effective February 21st, 3 visitors, including caregivers, will be allowed at a time per resident, and visitors that enter the home age 5+ must have 2 doses of the COVID-19 vaccine. By March 14th, the limit will increase to 4 visitors, including caregivers, at a time per resident, and then children under 5 will be allowed to visit with no vaccination required. Moving forward to caregivers. So right now, again, you're looking at the February 7th category. So 2 caregivers may visit at a time, 1 when in outbreak or in isolation, and up to 4 designated caregivers per resident. So previously we had a maximum of 2 unless they were previously designated, but we're increasing that. We increased that on February 7th to 4. And then on February 21st, it's just reflected the same. We have 3 visitors at a time per resident, and that can include caregivers. On March 14th, it'll increase to 4 visitors at a time per resident. In terms of social absences, so as of February 7th, we had resumed social day absences for residents who have at least 3 doses. And then in a couple weeks' time, on February 21st, social day absences for all individuals, no vaccination required, and we will also resume social overnight absences for residents with at least 3 doses. By March 14th, all social overnight absences will be allowed for all residents regardless of their vaccination status. And then on the next slide, we just want to remind you, whenever you are outside the home, residents should do their best to wear a mask as tolerated, wash your hands frequently, limit contact with others, avoid crowds and large social gatherings with unvaccinated people, and to remember to practice physical distancing and only be in close contact with fully vaccinated people, especially when eating or singing. And this is just to be mindful of the contact that can occur with the virus. And that is a wrap up for me on the easing of the temporary measures. So with that being said, I'm going to pass it over to our colleagues at the Office of the Chief Medical Officer of Health, Dr. Sarah Erdman and Danielle Remmer.
Thanks, Erin, and thanks to all of you for joining us today. I just wanted to walk you through a broad overview of some of the changes to the guidance for public health units on outbreak management in long-term care home, as well as case and contact management. So first, I'd like to start by saying that local public health units are the bodies that are responsible for investigating, declaring, and managing outbreaks under the Health Protection and Promotion Act. And long-term care homes must adhere to any guidance provided by the local public health unit when there is an outbreak or for case and contact management. So I think that it's important to know that sometimes advice might differ from home to home because of the nature of the outbreak, the home's design. So there is some variability out there, but the guidance is there also to provide some provincial consistency across public health units and across homes in terms of measures. So next slide, please. So for confirmed outbreak management, we're really trying to balance the risks to residents from COVID-19 with the potential harm that we're really hearing about isolation and testing measures. So we're trying to promote some activities while cohorting within outbreaks. So it's at the discretion of the public health unit, and it depends on the nature, again, of the outbreak and when it's feasible for the home to implement. But we're really trying to promote that when group activities, when areas of the home not affected by the outbreak, so certain floors and units, once the outbreak is contained to a specific floor, group activities, dining, and other social gatherings may be able to continue or resume if those residents are able to adhere to public health measures. Group activities within the outbreak area of the home may continue and resume for specific cohorts as the public health unit deems it safe. And certain activities for residents in isolation, so when they're in droplet and contact precautions, either as a case or as a close contact, may continue and resume again at the discretion of the public health unit and where feasible for the home to implement. And some of those activities could look like supervised and scheduled walks with one-on-one with a staff member or essential caregiver when both individuals are masked, supervised and scheduled outdoor time as well with IPAC measures in place. Next slide, please. So contact management, again, contact management decisions are made by the local health unit. So I'm going to walk through a little bit about what contact management is going to look like with the new guidance. So thank you. So we've provided for a new category for lower risk contacts in the new guidance. A lower risk contact would be a resident who is fully vaccinated and boosted with their 3rd or 4th dose and was in contact with a positive case during their period of communicability or their infectiousness period. But the exposure may be deemed to be lower risk. And I'll go into that a little bit on the next slide, what that might entail. And that's again determined by the local public health unit. Whereas I'm sure many of you are familiar with being a high risk contact, or also called a close contact, is a resident who is in contact with someone who is positive during their period of communicability or when they were infectious. And those could include receiving direct care from a staff who's positive for COVID-19, when there's a breach of PPE, or if the resident is higher risk because they're not fully vaccinated and boosted. Close prolonged contact with a symptomatic person, or in contact with body fluids of a positive case without the consistent and appropriate use of personal protective equipment. So next slide, I'll go through a little bit about what the management for those contacts would be. So you'll see that we're allowing for lower risk contacts for those who are fully vaccinated and boosted to monitor for symptoms for 10 days and not necessarily be in isolation. We still would recommend PCR or rapid molecular testing be taken on or after day 5, but isolation would not be required, as I said, unless symptoms develop or there's a positive test result. And so for those who are vaccinated and boosted, that might look like receiving direct care from a staff member who is positive for COVID-19, but that staff member wore consistent and appropriate masking throughout the encounter. It might also look like being in a shared indoor space with someone who's positive for COVID-19, but where public health measures were in place. So being in a common area where physical distancing and masking was in place, for example. For residents who have not received vaccination or have not received their booster, their 3rd or 4th dose, we would still recommend isolation for 10 days. And then higher risk contacts, the new change for the guidance for residents who are fully vaccinated and boosted with their 3rd or 4th dose is that they're able to discontinue their isolation on or after day 5 of receiving a negative test. For residents who are not fully vaccinated or have not received their booster dose, then they would still be required to isolate for 10 days from the date of contact. Next slide. So I'm going to turn it over to Danielle, my colleague, to go through some outbreak management scenarios.
Thanks, Sarah. And I apologize, everyone. My video has a mind of its own. Sometimes it likes to work and sometimes it doesn't. So for this scenario, a staff member becomes symptomatic and tests positive for COVID-19. They had provided direct care to residents for 2 days prior to their onset of symptoms. So during their period of communicability. So what are some of the questions that may need to be considered when managing resident contacts? So who may be in close contact with the staff member during their period of communicability? What were the residents or close contacts vaccination status? And was the staff member wearing PPE? And was it being worn appropriately and consistently? So we've developed a flow chart on the slide here to kind of work through that scenario. So if we start at the top, the green button, was the resident in contact with a positive case during their period of communicability? So the answer would be yes. Did the resident receive direct care from the healthcare worker who was positive for COVID-19? Again, the answer would be yes. And the investigation reveals that the healthcare worker had consistent and appropriate use of masking. So again, yes. And luckily the resident was vaccinated and boosted, so it would be yes, and they would be treated as a lower risk contact. So again, as Sarah mentioned, they would be monitored for symptoms, tested on day 5, and then isolation not required unless there are symptoms or a positive test. So for those residents who were not vaccinated, you can go through the same 3 steps, go to no here, and then they would be treated as a high-risk contact, where there would be droplet contact precautions, and they would need to be isolated for 10 days from the last exposure. So next slide, please. So for scenario number 2, a resident has a day visit with a family member. That evening, the resident attends a communal dinner with his or her dining cohort, which is comprised of 5 residents from their 30 resident unit. The following day, the resident develops symptoms and tests positive for COVID-19. So what would then happen to the residents that are in the same dining cohort? So typically the dining cohort would be considered high-risk contacts due to the prolonged and close nature of their interaction without masking and during the ill resident's period of communicability. So all 5 would need to be isolated, and the residents that are boosted, they would need to be tested on day 5. And if the test is negative, remain asymptomatic, they can discontinue isolation. So we can go through that again with the flow chart here. So again, they were in close contact with a positive case. Yes. Did they receive direct care? No. And then the answer to this, did the resident have close prolonged contact? The answer would be yes. So we can go all the way to the far right of the screen. And again, is the resident vaccinated and boosted? If they are not, they would be treated as a high-risk contact and isolated for 10 days. And then if they are, they would be treated as a high-risk contact, but they would just be isolated for 5 days and tested. And then if they do test negative, they can leave isolation. If they test positive, they would then be considered a case. And then always monitoring for symptoms of COVID-19. Next slide, please. So moving on to admissions and transfers. So homes are to follow the guidance for detailed requirements and information on testing and isolation of admissions and transfers into the home. So we did aim to clarify this section, particularly if a home is experiencing an outbreak and when the home would need to consult with the health units. So we developed an algorithm based on the settings and scenarios. And Sarah's going to walk through some of these scenarios for how to use it, similar to what I just did for the outbreak management. So I'll turn it over to you, Sarah.
Thanks, Danielle. So for the first scenario, a patient is admitted to a hospital. The patient is stable and then ready to be discharged back to their home. The hospital discharge planner contacts the long-term care home to discuss the transfer. So what are some considerations to support the patient or resident with a transfer back to their home? So some of the considerations that the discharge planner and the home might want to walk through are, is the hospital in outbreak? We find out that no. So I'll go to the next slide and walk through. So the healthcare facility is not in outbreak. We want to think about whether they're going to their home is in outbreak. And so upon consultation with the home, we find out that yes, the home is in outbreak. And so we want to think about whether any of the following apply. Was a new outbreak declared when there's ongoing investigation? Is the outbreak uncontrolled or uncontained? And that might be at the discretion of the public health unit. Would the transfer to the floor be where residents are unable to follow IPAC measures? And is the resident themselves unable to follow IPAC measures or public health measures? So we find out that none of those apply. And then we find out that the resident is vaccinated and boosted with their 3rd dose. So we would recommend that the transfer can occur even without consultation with the public health unit, given that we're trying to promote timely transfers at this time. So we would advise that screen and isolation would be required until a negative test result on day 5 because they're fully vaccinated and boosted. So we'll go to the next scenario. So in this scenario, a resident has been sent to the hospital emergency department by an ambulance. After they are assessed by the physician, it is determined that they are not required to be admitted and will be sent back to the home the following day. So again, we want to think about where the patient's coming from. I'll go through the flow chart. So the resident is coming from a healthcare facility where there may have been cases in the emergency. We find out that there may have been an outbreak and the resident may have been exposed to COVID-19 within the emergency department while they were there overnight. The resident has not recovered from COVID-19 in the last 90 days. The resident has not been exposed to COVID-19 in their home prior to admission. So none of those are applicable. Oh, so yes, maybe they have. So consultation with the public health unit is not required, but they would be managed as if they were a close contact because we cannot confirm that they were not exposed to COVID-19 during their emergency room visit. So the requirements again would be for if they're fully vaccinated and boosted to screen and isolate on arrival and until negative test results is obtained from day 5. And that is it for the scenario. So I'll turn it back to the moderator.
Thanks, everyone. That was a very informative presentation. I know our Executive Director, Dee Tripp, will have a few more remarks to add. Thank you.
Thank you, Melissa. Thank you for jumping in there. My mute button was not demuting or unmuting, so thank you for that. This opportunity today, I just wanted to pause for a moment and acknowledge that, you know, this opportunity today comes after and during a devastating period of time when freedoms were removed, residents' rights were in question, deaths occurred, residents, you've lost some dear friends and partners, and that's still happening. The negative outcomes of isolation and emotional neglect and support are real. The pace of the information that was given to you today, coming at you today, was very fast and in a rather matter of fact tone. So I feel I would be remiss if I didn't acknowledge the disconnect, the somewhat sense of disconnect between the emotion, the trauma, the grief, the frustration, and the patience that you as residents, as people living in long-term care homes, have had to endure the last couple of years, and your families and your friends and those the team members that support you. So with that being said, I would like to pause for a moment. It's important for us in this opportunity, this type of town hall meeting, to have a sense of who is with us today. So I would like to invite you to fill out or to click the buttons that will be on the screen very soon, the poll that will pop up in a moment. There it is, thank you. So we have a question for you. Please indicate your role in long-term care, where you fall. Are you a resident? Are you a residence council assistant? Are you an administrator? Are you a government representative? A family or essential caregiver, or another long-term care team member or staff, or other? If we haven't captured the category that best represents who you are, please click other. While this webinar today was intended for residents, we understand that at times there are other people, other long-term care reps that may jump into an opportunity like this. So it's very important for us to really understand who's with us today. We'll just wait a few seconds. This is the one and only question that we are posing to you before we switch into our Q&A. Okay, I think we are at 100% answered. Okay, thank you very much. So what we see is we have 42%, there are about 113 sites that have joined us today, recognizing that at each connection, each computer, each connection, there may be a group of people. So we have 42% residents, 34% residents council assistants, 5% administrator, 4% government representatives, 12% family and essential caregivers, and 23% other staff or other team members in long-term care. So thank you very much. That is helpful as we move forward and plan subsequent webinars like this. Melissa, I'm going to invite you, please, to join me as we navigate through some of the questions that have come our way from residents. Thank you. Hi, Melissa.
Yeah, we welcome anyone to share their or have your webcams turned on. I know residents like putting faces to names, and it's certainly it's something we try to promote where we can. The first question that popped up fairly early in our presentation was this one from Sherry. With the easing of temporary measures, is there a plan to reduce testing for visitors when coming into the home? Or right now it's everyone coming in the door being tested. So is that something that might, as part of the phased plan, do you expect that to taper down, I think is what Sherry's asking.
Thanks, Sherry, for the great question. I'm Dawn Mallett. I'm the director here on the pandemic response team. It is something that we are looking at. We are being cautious at this point with the easing of restrictions, especially as the province is also doing the same thing. And so a lot of the spread during this wave of COVID was in the community itself. And so we're just keeping that testing level the same at this time, but do anticipate as we watch the numbers and see about community spread and just outbreaks and numbers within the homes themselves, that we will be easing that restriction, and hopefully we'll be able to do so sooner rather than later.
Thanks, Dawn.
Thank you. So I'm going to jump in. I guess we can tag team, Melissa, if that's okay. So you can look at some questions while I'm speaking. Here's another one that came in from a resident. My long-term care neighborhood is currently experiencing an outbreak, but I'm healthy. Can I still go out on a social leave?
Maybe Sarah or Danielle, I'll ask you to answer that one.
Yeah, so I think that depends a lot on the scenario and what the public health unit is advising. If the outbreak is contained to a certain floor or unit and that resident is not a part of that, we would encourage that those day trips would be able to happen. If a resident is within the outbreak unit and is on isolation and droplet and contact precautions, or if the public health unit feels that the outbreak is not contained and is widespread throughout the home, then that may not be able to occur. That would definitely not be able to occur if they're in isolation and depending on the nature of the outbreak. But yes, if the resident is not within the outbreak unit, then yes, ideally it would be able to occur.
Okay, so the scenario, the specific scenario that was spoken through that question is within his or her neighborhood. So, you know, my neighborhood is currently experiencing an outbreak, but I am healthy. So the ability to go out on a social leave isn't necessarily tied to your own personal health. It's tied to the amount of the severity of the outbreak is what you're saying?
Yeah, well, someone could be healthy. It depends what you define as healthy. Someone could be healthy, but be a close contact and need to be in quarantine, unfortunately. So it really depends on what the public health unit is advising.
Okay.
Our next kind of question that's come through is more of an observation just around practice in the long-term care homes. I think the screeners at the front door are very vigilant about having every essential caregiver tested at the door, they wait the 15 minutes, they're cleared, and they proceed to the floor. And we've been hearing this from residents as well. I think this is a family essential care partner who's posing this question today for us. But it's been observed that team members or staff coming in for their shift, they get the swab, but then they proceed to punch in and go to the floor, oftentimes before that 15-minute window has passed. So they're not getting the test result or cleared at the door. They proceed to be on the floor, and then they're finding out that there's a positive case and there might be contact that's already happened. So perhaps you could speak to this, the best practice or the approach that should be followed by homes, because this does seem to be an inconsistency that we're hearing through our resident audience as well.
Absolutely. So yes, it's part of what we do. I'm going to use the word allow for lack of a better term right now, but is that staff members do not need to wait for their rapid antigen result before going into the home itself. And so our recommendation, definitely best practice, is that they would go in, go to their locker, get ready for their shift, but try not to go to the floor or try not to be interacting with the residents until they do have the result. This really was put in place right at the start of rapid antigen testing in the homes, and it came down to operational feasibility. It's difficult to have staff members waiting that 15 minutes outside, especially as there may be even just the time to get the person swabbed and everything like that. So we looked at the risk of this, recognizing that staff members are in absolutely full PPE. They're very well trained on PPE and other IPAC measures. And so it is a small added risk, I would say, but it's something that working with the chief medical officer of health and the homes themselves felt that the level of risk was sustainable. And as you saw from Dr. Erdman's presentation today, even if the staff member does test positive, if they're in full PPE, it's not considered a high risk contact.
Okay, thank you. There's a grouping of questions that I'm seeing coming in that talks about isolation, and when a resident is in isolation and then the isolation ends and then another resident has symptoms or a positive test, then isolation starts again, and there's a cyclical occurrence of isolation after isolation interwoven. There's one gentleman here, Donnie, who said that he's in 34 days. Currently, he's in 34 days of isolation related to Outbreak. When will this ease? Another related question from Gail: how many days in isolation is considered too many? So again, the concern is one isolation bleeds into another, leads into another, leads into another, and residents are spending weeks and weeks and weeks in isolation.
I can try to tackle that one. I don't know that there's a number. We hear loud and clear your concerns and the suffering that's going on because of isolation. We don't want that to happen. But right now, as we're coming out of the Omicron surge, we're trying to balance the risks of transmission and the risks of severe outcomes with the needs of the residents for not being in isolation, of course, for their mental and physical well-being and their spiritual well-being. So we really understand that. We're really working to have a balanced approach to this. And as we have worked with, watch the data, work with our stakeholders to improve the outbreak measures in homes, we're really keeping an eye on lifting measures as quickly as possible. So we really hear your concerns loud and clear.
Thank you. I think in that similar vein of isolation, residents are really keen to start to mix and mingle again. And many comments are speaking to the cohorting that's happening. Many residents have existed within the confines of their floor, their home area, their unit, their neighborhood for much of the last 2 years, even when there was kind of an easing of that restriction. Before Omicron, many homes, home leadership teams were still enforcing that's kind of segregation. So residents are keen to know when through this staged plan, when they might expect to start to mix and mingle again. Can residents come together in the foyer from different floors? When can residents start to have resident councils in a room together with representatives from different parts of their home? Because I think people are really missing that connection and those friendships face to face, not just on a screen.
Thanks, Melissa. So I can speak to this when not in outbreak. And I think, Sarah or Danielle will confirm that when in outbreak, cohorting is very much necessary and it's an important tool. When a home is not an outbreak, the ministry does not require cohorting, except when residents are dining. And dining is a very high risk activity, as the masks are definitely off, and just with the eating and everything like that. So outside of dining, there is nothing in our requirements, outside of dining and an outbreak, sorry. There's nothing in our requirements that says that the residents themselves need to be cohorting. So it may be a safety measure that the homes are doing and keeping in place to, help to cut down the number of key high risk or low risk contacts if somebody does test positive. And again, the public health unit may also be putting that in place to say, you know what, it is the safer for, if I may use that term, method to be cutting down the amount of spread of COVID-19 within the homes. For the residents' councils, we've tried to be clear in our guidance document, especially over the fall, and this is much thanks to those members on here who participated in our communications task team. Once we heard that the residents' councils weren't taking place, we were very pointed to the homes themselves in a memo from Erin Hanna, who spoke to you earlier, as well as her guidance document, being clear that they should be taking place. And, homes should be finding measures so that hopefully they can be taking place in person if the home is not in an outbreak, and, finding a location where physical distancing is possible if that's what the home should choose. As I said, unless an outbreak, cohorting is not necessarily required there. So there wouldn't be the reason not to have everybody in the same room.
Okay, thank you, Dawn. We've heard up to this point, public health having authority, and I'm looking at another series of questions that seem to speak to the inconsistencies that residents have experienced, the difference in lived experience over the last couple of years. And so the question is, who ultimately has the authority? My home, the Ministry of Long-Term Care, the Ministry of Health, or the Public Health Unit? And related to that, part B is, my home has been layering on stricter rules above and beyond ministry directives and local public health guidelines. What recourse do we as residents have when this is happening? So a question about who has the ultimate authority, and if the home is layering on top of ministry and public health, what recourse can residents have? Or what recourse do they have?
So I think with the ultimate authority, it's not a straightforward answer, and it's actually a layered approach. And so the ministry releases guidance and requirements, and there is a difference between whether something is a requirement. If it's in the directive, then it's a requirement. And so the testing and the vaccine mandate are good examples of that. Or I believe it was Sarah earlier mentioned Directive 3. And so that is absolutely, the homes must be following those requirements within there. However, on top of that, the PHU has their own authority that allows them to put on restrictions on top of what the Ministry of Long-Term Care or the Ministry of Health may have also put in place. And so that would be the first layer. And then, well, we would like the homes very much to be following our direction or the PHU direction as much as possible. They do have the ability to go above and beyond what we put in place. We really are trying to be clear about when it comes to regards to visitor access and residents being able to go out into the community, that if the home wants to put something above and beyond what the ministry or what the PHU has put in place, then they should be speaking with the PHU to see if there's a reason for why they would be doing so. But also that we've asked them to consult with the resident council as well, so that the residents do have an opportunity to weigh in on that. I think if they are going above and beyond, there is the Ministry of Long-Term Care's action line that you can reach out to. And then we also have our own pandemic response email address that we can share out with everybody as well, that if you really feel like they've gone too far, then you can reach out to us and we can look into that as well.
Thank you. Thank you. Another question is, or another group of types of questions seem to talk about the severity of illness, in that because residents have been vaccinated 2 and 3 times, most residents, the symptoms that are exhibiting in homes are mild flu-like symptoms. So the direct question is, are you monitoring how sick people in isolation are? Because our experience in my home is that residents are only exhibiting mild flu-like symptoms. So really wondering about the severity of restrictions when the illness itself is not presenting to the extreme.
So I'm happy to start on this one, and then we'll see if Sarah or Danielle, you want to layer anything on. We have been very closely monitoring within the homes, specifically homes in outbreak, and looking at how many residents are symptomatic versus asymptomatic, and trying to also get a measure of just even the severity within the homes. And so we are keeping a close eye on that. I think that information, it was very helpful when the OCMOH, so Dr. Erdman and Danielle, working with a number of public health units themselves to come up with the measures that we did put in place that we're sharing with you at this time. There is the difficulty that for even if many people it is not severe, there's still going to be a handful of people where it is severe, and there's not really a way to tell who is going to be more severe on. So Sarah, I'll turn it over to you.
Yeah, and I think that is great news, and we are seeing that and monitoring that very closely as we consider next steps and lifting of restrictions. And so I think that really speaks to the efficacy of the vaccination and the 3rd and 4th dose against preventing severe illness. That being said, when we went into the Omicron surge, we didn't know anything about this variant and how individuals in long-term care would fare given that they were vaccinated, but there was significant evidence that Omicron has very different characteristics, and the vaccine was not as protective. And that's why the measures, going into December and January were quite severe, I think. So I'm hearing your frustration, and I think it's positive news though that the level of severe illness is very low in the residents. So we're very much aware of that, and we're very much monitoring that for where we go with our directions and policies.
Okay.
Thank you. There wasn't one more question. I know homes have become more diligent with sharing ministry directives with residents. And I know the OARC bulletins are another way that we try to disseminate highlights from and kind of make sense of some of the information that's coming down the pipeline. There is a bit of a disconnect with the public health guidance, as that goes usually to the infection control lead in the home and is not always being shared. Like residents don't often get to see those directives or the information from the public health units. And this person who's posing the questions sometimes there's a reluctance to share the public health guidance with the residents. So is there a way that we can maybe promote a promising practice to move forward so that residents have a more fulsome picture of what's happening? I will shamelessly plug that OARC does have a communication tool. It's a template designed that home leadership team can plug in and attach memos, directives, OARC bulletins, but it's designed to give those high-level updates. What's happened? What is the picture this week in our home? How is the situation evolving? What are some of the anticipated changes to care and routines? How can we stay in touch with the people we care about? And if we have questions, who can we go to within our home and beyond our home? How can we elevate concerns? So I think it can be tailored at the home level based on resident feedback. What's going to work for residents? How do residents like to receive information? And it's likely going to be various formats, printed materials, word of mouth, updates at huddles, and that kind of thing.
I'll just add to that, Melissa. We're also at the ministry. Again, I'm going to mention the communications task team that we met with in the fall. We still have a lot of work to do coming out of that task team. Things were unfortunately had to be slowed down a little bit because of Omicron and needing to pivot a little bit that way. But we are hoping to be creating more templates, a best practices guide for homes for communicating with residents and the families. And so hopefully over the coming months, we can get more and more of those materials in the hands of the homes, and it will make it easier for them to be communicating with the residents themselves, and that the residents will see a lot of benefits from that. The ministry, we've been really working to be providing the plain language, be providing the key messages, handouts that the homes can simply print off and provide to the residents themselves. And I really do hope that the homes are providing that and the residents are feeling better informed.
Thanks so much. And I guess this is another opportunity to build a relationship between the resident council and the infection control lead in the home. So perhaps they could be invited as a guest for a short period on your meeting agenda, just again, for full transparency and for knowledge transfer. So that's another opportunity in the short term until that comes down the line. So thanks so much, Dawn.
I have a question, and I think it's best posed to Dr. Erdman, and it has to do with vaccinations. So I'm looking at a number of them. So I think there's a part A and a part B. First of all, most residents have had 3 vaccinations. There's talk of the 4th vaccination. Why would that be a requirement? So the level of vaccination is very, very high amongst residents, and they are still being isolated, as we've already noted and discussed. Part B to that is, if there is a resident who is not vaccinated, how can that resident be best, what advice would you have for that resident if he or she leaves on a social absence with an unvaccinated family member in an unvaccinated and enters a group setting where people are not vaccinated? So really it's a question around the importance of vaccination, why we would recommend that residents have 3 and then maybe even 4 doses, and what to do or how to advise a resident who is not vaccinated who wishes to go out on a social absence.
Well, for that one, I might defer to Dawn. I'm not sure. I can't remember the policy on absences for unvaccinated individuals at this time. But I would say why we're promoting 4th doses in residents is because there is evidence of waning immunity after a 3rd dose. A lot of the residents got 3rd doses in September, October. There is significant evidence that immunity wanes, and then you're more susceptible to severe outcomes if you do get infected with COVID-19. So I think that, again, to the previous question where I addressed the lack of severe disease that we're seeing in homes is really due to the high level of vaccination, and that's really, really promising. So I would just think that that's really important as we move forward going into, we don't know what the future holds right now, what new variants might come. But that being said, that I think that the vaccination schedule is being looked at. It's an evolution as more evidence comes and as more variants might emerge as to how we're going to address that, if it's a yearly vaccine like a flu shot or how that will work. So I can't comment on that right now, but there's a lot of work being done to address how that will look in the future. Maybe I'll hand it over to Dawn for the unvaccinated policy on visits, but I would say that that resident would be at higher risk of severe outcomes if they do get COVID-19 and if they're mingling with unvaccinated individuals on a social absence, then there is that risk for that individual.
And thanks, Sarah. So I just double checked the date on it. And it looks like as of February 21st, residents who are not having at least their 3 doses, so unvaccinated or any level of vaccination, will be able to go on day absences. And then by March 14th, they'll also be able to go on overnight absences. And we recognize, this is an increased risk of bringing COVID-19 into the home. It again just goes back to just trying to balance the risk of COVID coming into the home with the residents' rights to be able to see their family members, to go out into the community. And so that's why even the timelines were shifted so that we didn't put it as part of the first phase of these easing of measures. And ultimately, especially with the residents, it's come down to it's their choice whether or not they want to be vaccinated. And we are trying to just kind of educate everybody as much as possible the benefits of the vaccinations, as Dr. Erdman just spoke to, as well as just how you can be safe when you are out in the community as well. And so, as Erin spoke to during the presentation, trying to avoid mingling with people who are unvaccinated as much as possible is definitely one of those recommendations. But of course, we can't prevent people who go out into the community and say, you can't go see this person because they're not vaccinated.
Thank you, Dawn. We have just a couple of minutes left. I'm sorry that we are not able to address all of the questions, but as I said on the onset, we will collect all of the questions. We will circle back with our ministry partners and create a next steps document, whether it's a Q&A document. Just before I give some final closing remarks, coming out of what you were just saying, Dawn, around residents' rights and citizenship of people living in long-term care, I'm just wondering what, if you might be able to comment very briefly about how you reconcile as government decision makers, government policymakers, how you reconcile the notion of doing what is right and best for public health and for the health and safety of residents and people in our province. How do you reconcile the removal of freedoms and residents' rights? There are many comments in our question and answer box around residents feeling like they've been imprisoned, that they have had their rights stripped away, that they would rather be sick, physically sick, than have more isolation and be kept away from the freedom of seeing those that they care for and love. So I'm just wondering if you could end on that before we end our webinar together.
Thanks, Dee. And recognizing how hard the pandemic has been for the general public, but I would think even more so for the residents, so yourselves who have joined us today. And it's been very much just working closely with the experts to look at the evidence and look and trying to balance it. And that's a word we've used a lot, especially recently, of what is the risk. And as Dr. Erdman mentioned earlier, when we did put in restrictions or temporary measures back in December, it was because of the unknown. It's really hard to know that a new variant of concern is coming out, and we don't know how it's going to affect residents and what is going to be the severity of it. And so trying to balance that with the residents having their health and their well-being and being able to see their family members. There's been definitely a lot of lessons learned throughout this pandemic, and I know for a fact that we will be continuing to do lessons learned throughout just this wave, and definitely looking back and saying, okay, where did we go too far and what can we do in the future? And you know, hopefully as we do continue these conversations with the residents, we can have your input and your information shared with us, because that's invaluable to us. I've learned so much at my time at the Ministry of Long-Term Care because of speaking with not just the homes themselves and the other health system partners, but also speaking with the residents, and the emails that we get from the residents and the family members. Those make a big difference to us. Those really help us in understanding exactly what you're going through, because it's hard. I don't work in a long-term care home myself. I don't necessarily get that interaction. And so, you know, I really appreciate those. And again, I hope we have this continued conversation so that we can get it right, or at least, you know, but recognizing we are trying our best, and hope that everybody's just able to stay healthy, but also happy is an important part of that.
Thank you so much, Dawn. Well, everyone, we started at 10:02 and it is now 11:02, so we have used our full hour together. Those of you who've joined us, residents, you have our commitment from OARC, from our team, your team at OARC, and our ministry partners, that this is the first of several opportunities to come together in a town hall fashion. Next steps on our end, as I said, we will gather all of the unanswered questions. We will create another tool that will be available to you. This webinar was recorded, as I said. We will be sending out a bulletin within a day with a link to this bulletin, or sorry, a link to this webinar and the slide deck that was shared as well. There's a lot of information that came at you, so hopefully in the days and the weeks that come, you will be able to sit and view the webinar again and pause it and think about what you've just heard and really digest all of the information that's come your way. So on behalf of your team at OARC, I want to thank you for spending this last hour with us. Thank you, Dawn. Thank you, Aaron. Thank you, Dr. Erdman and your teams for all of the behind the scenes work that went into this time preparing for today. Be well, and please don't hesitate to reach out to us at OARC. Thank you. Enjoy your day.
Thank you.